I know it's a mixed audience, and we will be talking about cancer-associated thrombosis. Cancer-associated thrombosis means that it's a thrombosis which occurs in cancer patients. And cancer patients, it dealt in oncology, is not on oncology, but many other areas as well. So obviously, it will be very much advantageous for many people. We know that we were just using low molecular weight heparin for many years. We are tuned to low molecular weight heparin very well. So I was talking about CAT. So CAT is just a cancer-associated thrombosis. So there are many other types of CATs as well. So we'll not go into that. So there is this kind of CATs which you might have seen in the cinemas. But there are other cats as well, like snow leopards. So this is endangered animal, and it's a Himalayan area where it is found mostly, where the foothills I live. So we'll go to the cancer-associated thrombosis. So we will be talking about emerging concepts and paradigm shift, which is happening for last few years now, and a lot of new things are coming up. So we will talking about this all together. In the past, if you go 10 years ago, so there was no much problem. So you just a patient comes and just start the low molecular weight heparin. Now with the invent of DOACs, which is direct anticoagulant inhibitors, we have much choices. So when there is lot of choices, then there is a problem as well. So there are lots of challenges which comes with this type of treatment actually. So I'll just go through this. This is my disclosures. And so what we will talk about today is the incidence and the background, and then briefly pathophysiology and the standard management, what's happening with this treatment, and update on the oral anticoagulants. Previously, they were called new oral anticoagulants, but they're not new anymore. Since the last 5 years, we are using, everyone is familiar with them. And we will just touch on current guidelines as well. So current guidelines will guide us whether what we are doing actually in our practice and whether we are following these guidelines or no. Usually the audit will tell us these things. So I will present a case. It's a real case actually. This is SM, and she actually is a 52-year-old lady, and she had diagnosed with early breast cancer. She had a wide local excision and nodal biopsy, and it was estrogen receptor positive, and she was started on tamoxifen. While she was just a 6 months course, she had recently finished the chemotherapy. So chemotherapy had finished. She was receiving radiotherapy. And day when she was on radiotherapy, she started complaining of some pleuritic type of chest pain. And she came in A&E actually. She was seen in A&E, and oxygen saturation was perfectly fine. D dimers were less than 300. So diagnosis was not very sure about, and she was sent home with painkillers. The pain continued actually, and she started complaining of shortness of breathing. Next day, she came to my clinic, and the pain was there actually, and she was same oxygen saturation 98%, but she desaturated while walking. So I made her walk, and her oxygen actually dropped to 92 from 98. So immediate CTPA was requested. It has shown right-sided PE. She was straight away started on low molecular weight heparin. Tamoxifen was changed to anastrozole. The patient refused low molecular weight heparin. She said, "Okay, I can't." Actually, she took for around about a month or maybe, and in the follow-up clinic, she came. She said, "Okay, I can't take this any anymore. This is too much for me." This is the CTPA. You can see there is a large thrombus there on the right pulmonary artery and sitting there nicely. And what is the best management? What is the long-term approach for this patient? This question comes in the mind. Is it the low molecular weight heparin, continue whatever she says, or just give it for life actually, or change it to low molecular weight heparin to warfarin for 6 months, or change to DOAC for 6 months, or give initial low molecular weight heparin as she has already taken for a month, and then switch for another 5 months for doc. So the last two are okay actually at the moment, because the new guidelines have said that you can actually either start straight away so these patients on docs, or you can actually start with low molecular weight heparin and then switch to DOAC actually. So the last approach is the best one, because whenever you are starting in A&E, you don't know whether what patient is getting, what concomitant drug to drug interactions are, and you can actually always straight away start low molecular heparin. That is the safest approach, although you can straight away start low molecular in Pixaban as well. So I will go through in detail. So what is the actually burden? The VT burden in cancer patients is very high. So 1 in 5 patients with cancer will be diagnosed with the either PE and or DVT. VT is an umbrella term, so it covers actually DVT and PE, and it also covers the arterial thrombus actually, because with the new invent of different kinds of targeted therapy, we have seen that the arterial thrombosis have gone up, and they can get myocardial infarction as well, and the stroke as well. So this arterial thrombosis is also a problem. The treatment of CAT is quite complex, economical burden as well. So the morbidity and mortality and hospitalization increases when the incidence of VTE actually goes up. And this one actually is complex because there is an increased risk of recurrent thrombosis in these patients, and as well as bleeding as well. So bleeding could be directly due to the cancer, or bleeding could be due to the anticoagulation as well. And why not to prevent this clot happening actually? The all parties parliament committee actually met in 2016. When the data came, it was astonishing for them. So I will go through briefly into this. So not all cancers are the same. As you can see from this slide, the pancreatic cancer is on the top. So the incidence of pancreatic cancer and VTE go hand in hand. So the second is the lung cancer, the other cancers as well. And then in the last one is ovary and the colon and the prostate cancer. So the incidence actually varies from the cancer to cancer. And also within the cancer itself, if you take lung cancer, so there's a variety of lung cancer like squamous cell carcinoma or EGFR positive lung cancer. So the incidence of VTE is 10 times higher in EGFR positive lung cancer. Why? We don't know. This is a new data just turning out from different parts. So what is the pathology? This is 100 years ago, more than 100 years now. Virku has actually given this triad, and this is true today as well. If you see, there are three vascular injury happening to the blood vessels: endothelium, the stasis, hospital admission, surgeries, or maybe patient is not moving. So while they are on treatment or chemotherapy, so encourage your patient, keep moving, keep walking actually, because they're helpful, and their hydration is very important. And endothelial injury can happen due to chemotherapy, or due to any other reason, or due to invading cancer into the blood vessels. So all these things can actually lead to thrombosis, and it can activate all the cascade. So there are lots of pro-coagulants secreted by the cancers, and decrease in anticoagulant activities. The platelet activities go high. So the clotting actually is a multifactorial phenomena. So this is kind of pathology and background behind it. So there are lots of risk factors. So CVC catheter, central, and the age of the patient. Real world data is very important. In trials, you will see the performance status 1 or 2 are selected. But when we see patients in the clinic, their performance status is 4 or maybe 3. So all these things are very much important. And whether patient had the recent abdominal surgery, or whether what is the stage of the cancer? Is it early stage or is it late stage? and what is the initial period, whether they are in the initial period of their chemotherapy or in the late phase, and what kind of chemotherapy they are getting. Are they getting target therapy, immunotherapy, or some other things? And there are some parameters as well. These parameters are very important now. We know that hemoglobin, leukocyte count, and the platelets, they are part of the corona score actually. So if you know if there is a leukocytosis before starting chemotherapy, if there is a low hemoglobin, and if there is a thrombocytosis, then there is a high chance that they may get thrombosis, and the corona score goes up. So these are the parameters they measure, the type of cancer, and also these blood parameters. So D dimers is also one of them. Uh, Mostly D dimers are high because of the cancer activity. Now, uh, previously it was said that the cutoff value was low, but in cancer patient, to make it positive for DVT, they are considering as the new study has come up that the cutoff value may be more high, because negative predictive value for D dimers is very high, but we never find negative value in cancer patients high. So value of D dimers is controversial actually in cancer patients, and they have suggested to do CTPA or D Dopplers for these patients if you are suspecting that they are having VTE. So now if you see the malignancy, you can see the hematological malignancies are there on the top, and that this is risk of VTE by type of malignancy. We have already seen a slide in the lung cancer is high, GI cancer is quite high. And similarly, there is pancreatic cancer. The GI cancer actually is pancreatic and upper GI cancers. This is how we can actually see the early stage cancer and the late stage. When patients have a metastatic disease, then there is a high chance that they will get more thrombosis. Like you see, it's 4 times more in metastatic disease in 2 years study. In the same patient, during the journey of the cancer treatment, the risks varies from time to time. So when they are hospitalized, the risk goes up. When they are ambulatory, the risk goes down. When they are on chemotherapy, the risk goes up. When they are in remission, it goes down. But when it comes to end of life, then it goes up again, actually exponentially. So there is also controversy between treatment with anticoagulation when they are on end of life. So the guideline now suggests not to give them anticoagulation if their expected life expectancy is less than 3 months actually. So it comes the palliative care team. So we will talk about it in detail later. This is just occult cancer. So there is 10 to 20% patients when they have unprovoked DVT or unprovoked PE to actually investigate them for occult malignancy. And previously they were suggesting to do abdominopelvic CT scan. Has suggested that abdominopelvic CT scan is not very helpful. So you have to just do the routine blood tests, liver function tests, D dimers and some other blood tests, full blood count. And then based on those ones, you can actually individualize patients. And if there is some suspicion or indication or red flags, you can say red flags of malignancy, then you can investigate on individual basis, but not across the board. So pathophysiology, as you know, is very complex, is still not very well understood. But if you can say it's a platelet activity, suppression of fibrinolytic activity, and production of procoagulant by the cancer. So all together lead to thrombus formation, and this is very heightened in advanced malignancy actually. And if you see here, so there are tumor necrosis factors, the platelets, neutrophils, and monocytes all play a role. This is from the tumor. Chemotherapy itself damages the endothelial cell wall, and a lot of substances are secreted, and they actually lead to thrombus formation. We care, why should care actually? Because over last many years we have noticed that VTE and mortality go hand in hand. And if you see here in 20 months, actually 2 years, or usually the VTE is higher in the fourth cycle of chemotherapy when they are like 3 months or 4 months from the diagnosis. So we should, and the mortality goes up as well uh, with the diagnosis of VTE. If VTE is not there, the mortality is less actually. If you see here in this slide, you can see with the combination of cancer and the VTE, mortality goes high exponentially. And similarly, in this slide, you can see how common is the recurrent VTE in patient with cancer. So the recurrent VTE is also very common in and the readmissions with the DVT in those patients who have already history of VTE is almost double. Now, aims of VTE treatment. So what should be our aim? So our aim would be to reduce the incidence of recurrent VTE and to reduce the incidence of fatal PE, because they can actually have like whatever, if they have DVT, they can actually throw ambulance. So we have to reduce that. So if we anticoagulate them, and we also need to reduce the extension of thrombus, because it can embolize, it can extend, and it can be very symptomatic with swelling of leg or swelling of arm or anything. So it can be very painful. So these should be the aims actually. And if you see these studies, sorry for the slide, it's quite small, but main thing is actually these are earlier studies. One of them I will definitely mention it. It's uh, Agnes Lee studies clot. The second one is the catch. The clot study actually was comparing, previously we were all giving anticoagulation with the warfarin if you go like 40 years ago. So the clot study 30 years ago had shown that if you see the first here, the first one, can't actually point it out. So this one, the A, if you see here, so it is favoring to low molecular weight heparin. So these are 4 studies, clot, catch, and all those studies which were comparing warfarin with low molecular weight heparin. So it was favoring low molecular weights because low molecular weight heparin was actually reducing the recurrent thromboembolism. So it was favoring. So, but in the second slide here, it was favoring vitamin K in warfarin because the major bleeding was actually less in warfarin because we were monitoring it actually. But in the low molecular side, there was it was more bleeding. But still, we were actually we agreed to actually continue because it was not statistically significant. This is a meta-analysis, and we found that low molecular weight heparin is the standard of care actually since last 30 years. So the unmet need. So this is unmet need was detected because we were only stuck to low molecular weight heparin actually for last 30 years. We needed randomized controlled trials with the new oral anticoagulants. We found a lot of new oral coagulants. They were used in orthopedics. They were used in other areas in the atrial fibrillation. In non-cancer patients, but they were not being used in cancer patients. So we needed head-to-head trials in cancer patients with docs and low molecular weight heparin. And we also needed extended anticoagulation beyond 6 months because there was no data available, and still there is no data available beyond six months. And we also needed to actually churn some data for drug-to-drug interaction because P glycoprotein and also cytochrome in the liver can actually inhibit the metabolism and can affect the level of drug which we are giving them orally. So interaction between different drugs. So there are lots of drugs patients are on, especially the cancer patient. They're on immunotherapy, they're on target therapy, they're on hundreds of types of chemotherapy. So we have to look for whether they are individually interacting with these oral active. So these are challenges actually, and these are basically were unmet needs, and they are still unmet needs. And I have published them in last year in my article, in my review article. So What most important thing is the patient satisfaction. Patients are not satisfied with daily injection. They are worried about, so every day one injection, every day. So these are unmet needs. We have to do something about it. So this was going on for the last 4 or 5 years. And there were a lot of trials going on actually. And we suggested that a dedicated cancer associated thrombosis pathway, it should be ideal for these patients. And we call them cat clinic. They have started in Wales. After this article, there are few pathways already designed. So it's led by the person who is interested, oncologist who is interested in the cancer associated thrombosis, pharmacist from the pharmacy who is expert in looking at drug to drug interaction, because we have to look for those patients as well. So all these people and the nurse specialist who can actually talk to the patient and tell, because patient satisfaction is very, very important. They should know what they are taking and what is the incidence of their bleeding and what is the incidence of their recurrent thrombosis. And these are the actually data from different trials we have collected. So this meta-analysis was published few years ago actually, because these are those trials which were just done for other reasons, like just for atrial fibrillation, for heart patients, for orthopedic patients, Einstein's DVT studies, for normal population. These were quite huge number of people actually. If you join all these trials together, Hakusai VTE, Amplify trials, they were just checking these docs in different types of population. So these are 30,000 patients. So in them, we have found out there were 1,000 patients luckily were unluckily were having cancer, and they were given docs, and we found out that they did very well actually. There was no problem in them actually happening. So so the analysis shows that safety and efficacy of direct oral anticoagulant in cancer patients on this meta-analysis was okay actually, but there must be a selection bias, because these patients were very well, they must be in remission, they must not be like a performance state is very good in like one. So this, can you see in this meta-analysis where 1,000, more than 1,000 cancer patients, they were all favoring apixaban, rivaroxaban, edoxaban, dabigatran. So this is recurrent VT. So when you give these things to cancer patients, the incidence of recurrent VC reduces. So this is from the meta-analysis. This is not the randomized control trial. I will come to the control trial in a minute. So if you see the bleeding also less. So although this is a selection bias there must be a good cancer patients. I can say they may not be on anti-cancer drugs. They may not be having any interaction between different drugs, but the bleeding incidence was less as compared to low molecular weight heparin. So in few years ago, this published, I think is 4 or 5 years ago, we were knowing that drugs are okay for cancer patients, but we were not satisfied because we wanted randomized controlled trials. So drugs appeared effective and safer treatment for VTE in patients with malignancy. But there was a problem because we needed to compare drugs directly to the low molecular weight heparin, not with this type of meta-analysis. So we need a large randomized clinical trials. So there are lots of large randomized clinical trial already underway. 4 has published. So I will briefly discuss their results. And there was we know that docs are a reasonable alternative to low molecular weight heparin in the management of cancer associated thrombosis so far with this meta-analysis. Now, these are the snapshot, which is very good actually, because if you see here above the arrows is those trials which are already published, and the below the arrows are those trials which are underway. On the left side is the prophylactic trials, with the prevention. So it's a good to think about preventing the clots from the from the beginning actually. But if the clot happened, these are the trials which is already published. So Hakusai trial, Select D trial, and ADAM-VTE, and now CARAVAGGIO trial is also published recently. So all 4 trials is now published. So I will go through all these 4 trials or 3 trials. I will just leave the first, the ADAM-VTE, because it's a very small trial and there is a bias as well. So Hakusai trial was comparing edoxaban with low molecular weight heparin. Select D trial was a purely UK trial comparing rivaroxaban with the low molecular weight heparin in cancer patients. And CARAVAGGIO trial was comparing apixaban with heparin. So this is the treatment ones. And on the lower one is the prevention. So prevention is the 2 trials have published already: Cassini trial for rivaroxaban and Avert trial for apixaban. So this is a totally different ball game. I will not discuss it today because it needs a lot of time. NICE has actually suggested to consider prophylaxis in pancreatic cancer, but recently ASH, the American Society of Hematology, has suggested to use Corona score. If Corona score is above 2 or 3, then consider prophylactic. And you know, the dose of prophylactic anticoagulants is slightly lower. Either you can use low molecular weight heparin. In these 2 trials, they have used the Cassini trial has used half the dose of rivaroxaban, and in Avert trial they have used half the dose of apixaban. Normally we give apixaban 5 milligram BD. Here they have given 2.5 milligram BD. So obviously in prophylactic you have to give half the dose. So this is the prophylactic area. So I will leave the prophylactic area because otherwise it becomes too much. I will just discuss Hakusai trial now, and then Select D and CARAVAGGIO at the end, and then come up with some guidelines which is already published, and then close the talk. So this is the inference. So if you see, the directly acting oral anticoagulant were introduced on and after 2008, and there were 5 currently in the market, and these are like this. So dabigatran is the only one which is a direct thrombin inhibitor. Rest of it is uh, factor 10 activated factor 10 inhibitors: rivaroxaban, apixaban, edoxaban, and betraxaban. Only this above 3 are tested. Dabigatran, NCCN guidelines say that we can use dabigatran, but there's no good data. The good data is available for apixaban, rivaroxaban, and edoxaban, uh, but the other ones no. So I will talk about them individually. They were also previously referred as NOAC, but nowadays we are telling them DOAC. DOAC for VTE in cancer patient recently emerged new therapeutic option, easy to administer, no dose monitoring, no laboratory checking as we were doing in warfarin. So they are appropriate in cancer patient, but there is some challenges. So there is a fear of increased bleeding because the level can go up and down. The pharmacodynamics can go up and down because of different reasons. Organ compromise, when there is a liver or kidney deficiency or compromise, then their dose should be reduced actually. Child PO class A is fine, but B is we should not give it in B and C as well. So similarly, in creatine clearance less than 30, DOAC should not be used, or used cautiously between 30 and 50. Extreme weight is a problem in cancer patient. They lose weight, so we have a standard dose. So if you give standard dose to a very thin, lean patient, so the amount will be more. And you know, there is a lot of drug to drug interactions, so it can actually interact with the different kinds of drugs, and it's a P glycoprotein and cytochrome inhibitors in the or inducers in the liver. And there is oral absorption. Sometimes patients after chemotherapy, they are vomiting for 3 days and they're not able to take oral. If they're not taking oral anticoagulant for a day, they will not be protected. And sometimes they develop diarrhea on anti-cancer drugs. So we can't actually rely on absorption of these drugs when they are having diarrhea. So these are real challenges, and there is a lack of monitoring. No, we have to give it, and patient keep taking it. If the diarrhea, it will not absorb, so we don't know whether it is working or not working. So that's the problem actually. So the platelet fluctuation is another issue. So platelet with the chemotherapy can go up and down. If platelets are less than 50, then use of anticoagulation becomes controversial and becomes dangerous as well if they are below 20 or 25. So in that is the reason, these are the challenges. That's the reason we have suggested dedicated pathway for these patients, so where they can come and actually sit with someone who is actually looking into them holistically, looking into their performance status. Trial is actually is a selected patients. They have not included in brain, for example, brain mets. They have not included uh, performance status 3 patients. They have not included those patients who were on many polypharmacy or those drugs which were actually interacting. So the trials were actually selected patients. So we need a real world data here. So that's the importance of real world data. So when patient comes and sits in front of me with the performance status 3, and the is on hundreds of drugs and is on chemotherapy and some kind of other drugs as well, and his cancer is progressing, then it's a challenge. It's a challenge for every physician. We should have a pathway for these patients. We should ask the patient what is the best for them. Recent studies have shown, I was just reading an article just published last month, this one in the journal. It has actually shown that patients are unaware. They were not knowing the risk of thrombosis. Cancer patients were not knowing, and nobody has told them what chemotherapy is doing them, whether there is increased risk of thrombosis. And even if they have had thrombosis, they don't know what the implications are, what the life expectancy, what the incidence of recurrent thrombosis. So they need a teaching. They need a sitting with someone for an hour and talk to it. So we need a specialist nurse. We need some pathway. We need a dedicated MDT. We need a dedicated Cancer Associated Thrombosis clinic. We call it CAT clinic, which is already started in different parts of the world. Now, these are the 3 trials. So first one is the Hokusai trial. So this was comparing directly all cancer patients they have included. Performance status 2, they have not included the performance status 3. They have excluded brain mets. They have excluded some other drug-to-drug interactions as well. So arm 1 was deltaprine as a standard dose, 200 international units per kg for a month, and then reduced to 150 for 6 months. But actually, this trial continued for 12 months. This is the only trial for cancer patients for 12 months. And on the treatment arm, they have given low molecular weight heparin for 5 days because edoxaban takes time to 5 days low molecular weight heparin and then change to edoxaban 60 milligram. And if there is a renal impairment, we have to reduce to half the dose, 30 milligram. So this is the result actually. So it is a composite outcome. So it means the edoxaban and deltaprine was equal. So it's a composite means primary endpoint in this trial was recurrent VTE and the bleeding. The bleeding is high in the edoxaban, but recurrent is less. And similarly, the deltaprine, the bleeding is less, but recurrent thromboembolism was more. So it is this imbalance, and they put it together, and they said it's a primary endpoint together, composite. So in that way, it was actually equal. But if you see individually, if you see the major bleeding was slightly more in the doxaban, and also the recurrent VTE was slightly more in low molecular weight heparin. So on one side, it was more efficacious, but on the other side, it was dangerous. But when you put it together in the third slide, both comes back as equal. So they suggested that no problem. So the outcome is composite outcome was good. But when you have a sub-analysis, so when we found out where they were bleeding, which type of cancer were bleeding more, so they have found out when they have looked at it. that upper GI and gastrointestinal cancer and GU cancer, the epithelial type of cancer, they were bleeding more. So then guidelines came up, okay, don't give doxaban in gastric cancer and pancreatic cancer, and also the urinary or bladder cancer, because they bleed more. So if you here see the deltaprine, they're not bleeding. On this side, they are bleeding more. So that's why this came up last year. Now, let's go to the second trial. What the second trial has shown. This was a purely UK trial, and this compared rivaroxaban, and this was done by Annie Young in Warwick University. And they actually compared with low molecular weight heparin with rivaroxaban. So deltaprine 200 milligram as a standard care for 1 month, and then it was changed to 150 later on after 1 month for total of 6 months. So this was a 6-month trial, but actually it was continued for total of 12 months because there was a lot of bleeding initially. They found out, and they have actually have to put an amendments, and they have stopped giving it to in gastric cancers when the amendments came up. So the treatment arm was rivaroxaban, initially 15 milligram, and then changed after 3 weeks to 20 milligram. So 15 milligram twice a day means 30 milligram total, and then it reduces to 20 milligram after 20 days, and it continued for 6 months. And this was the outcome. So they have found out the recurrent VTE was actually less in rivaroxaban, but more in deltaprine. So it means that rivaroxaban is more effective. But when we look at the bleeding, bleeding was more in the rivaroxaban. When we have done the sub-analysis for this trial, it has found that upper GI cancer had more major bleeding with the rivaroxaban, and clinically relevant bleeding was also more in those patients. So if you see, this is the problem here with the docs. Then there are select patients where they bleed more, although they are more efficacious. Their efficacy is good. It's better than the low molecular weight heparin. So now the third trial. Third trial is actually comparing apixaban with low molecular weight heparin. Now apixaban, if you see here, they started with 10 milligram, and 10 milligram was reduced after 7 days, and then they have actually continued for uh, 5 milligram after that. Initially 10 milligram, and then 5 after 5 days, 5 milligram for 30 days. The other arm was standard arm, and they have not recruited brain tumors or patients with the brain mets, and they have also excluded performance status as well. They only recruited performance status 1, and those patients who are having interactions with a lot of drugs, they have not actually, and the renal failures and the liver failures, they have not included those ones. So this is the result. If you see here, you can see this trial is showing that deltaprine apixaban is better in terms of recurrent, as well as it is better in terms of bleeding. So less bleeding, and the recurrent VTE was less as well. So oral apixaban was non-inferior to subcutaneous deltaprine for the treatment of cancer patient. This is the result of CARAVAGGIO trial. And thromboembolism without an increased risk of major bleeding. So the problem here, the previous two, rivaroxaban and the previous edoxaban, have shown more bleeding. But in this trial, it has not shown more bleeding. So there was a question whether there is a selection bias. But this is a big trial actually. So this was done in 112 countries, and it was done more than 1,000 patients, 1,200 patients. So is a good data actually. So immediately a sub-analysis was done, and to look for bleeding, whether there was a GI bleeding and what type of cancer patients were recruited, whether there was a good so across the board recruitment was. So this was a slide which shows you that bleeding was actually in upper GI was equal in low molecular weight heparin, and also in apixaban group in CARAVAGGIO trial. So this gives us an idea that the bleeding was not more in those patients with the apixaban. Now, is it a class problem or is it a trial problem? This remains to be answered. If you see here, you can see the total cancer patient. There are lots of different kinds of cancer patients. So deltaprine and the pixaban both are equal, and the bleeding is equal. And there is the gastrointestinal cancer patients with the major bleeding have more or less the same in the both arms actually. And major bleedings are those where the hemoglobin actually reduces 2 gram. The patient is admitted for multiple blood transfusions, or patient had died, or patient has to undergo a major surgery to stop bleeding. So this is a major bleeding. And the non-major bleeding is those ones where patient has contacted the healthcare and they have come to the hospital, but it was not that low, but it was managed. So that's called relevant bleeding, but non-major bleeding. So if you see here, gastric cancer patients with major bleeding, they're all equal in both sides, and very nicely depicted in the graphical form, in column form. If you see here, so clinically relevant on the right side is a clinically relevant non-major bleeding, and this is clinically relevant non-major bleeding on the other side as well, GI bleeding with all patients, and this is for gastrointestinal cancer on the right side. So in both sides, it has not actually increased. So oral apixaban appear to be well tolerated alternative to low molecular weight heparin after this trial. This trial is just published recently, and the treatment of patients with CAT across different types of cancer, including gastrointestinal malignancy. So this trial has solved the mystery and solved the problem which previously true trials have shown us. The greater practicality of apixaban is compared with low molecular heparin suggested this drug as a preferred therapy for CAT in large proportion of patients with cancer. Further studies are still needed because these studies are still on selected patients, and there are lots of things still unanswered, like drug to drug interactions, and there is no data available for drug to drug interaction, and there is no data available beyond six months actually. Now, when these trials come up, then the guidelines also come up one after the other. So drugs are sometimes considered an alternative to subcutaneous low molecular weight heparin for CAT patients. So guidelines and consensus have advised use drugs in patients with CAT, but with exclusion of, this is the initial, they excluded the gastrointestinal and urinary or bladder cancers or kidney cancers. And these are the guidelines, one after the other. It actually came in 2019. If you can see here, yes, 2017 ESMO guidelines came up, and then there is a further guideline from NCCN, and international clinical practice guidelines also came up. They're also suggested actually, because the data was churning out, and these guidelines keep coming every year. This is 2019 guidelines. So if you go through them, they suggest that you can use DOC and consider it, but they were cautious at that time because they suggested not to use in gastrointestinal cancers and urinary cancers. Then ASCO guidelines also suggested in 2019 that you can use DOACs, and they have preferred DOACs as a first line. And then ESMO guidelines have come up. Well, the Spanish guidelines followed. So I think there are a lot of guidelines around, and each area and each body is actually producing new guidelines and over guidelines. So these are guidelines of ASCO in 2020, which I want to share with you because these are most current, and I will also share with you ASH guidelines, which is American Society of Hematology guidelines. So the ASCO actually has said that initial anticoagulation may involve low molecular heparin or unfractionated heparin or fondapaxine or rivaroxaban. So this is initial. So whenever you start anticoagulation, it is started in three phases: initial anticoagulation, and then long-term anticoagulation, and then extended anticoagulation. So three phases. So first 1 month or first 1 week, and then 6 months, and then extended beyond 6 months. So they have actually said that for initial, you can start rivaroxaban, because that was the trial which was done here in UK. The SLEC-D, rivaroxaban was started without low molecular weight heparin in treatment arm, and or you can start low molecular weight heparin among those patients which have a good creatine clearance. For long-term anticoagulation, you can start adoxaban as well, because adoxaban was not started initially. Initially, you always started with low molecular weight heparin with Hokusai trial. So when you are considering adoxaban, you have to start with low molecular weight heparin. So they suggested you start with low molecular weight heparin or adoxaban or rivaroxaban for these patients. And you have to consider not to give them in a high risk patients like gastric cancer, and also for genitourinary cancer, and also those patients who are having drug to drug interaction. And they also suggested beyond 6 months, consider on individual grounds. Time NCCN guideline came up, they have actually added dabigatran as well in that after the first 5 days of parenteral anticoagulation. So they suggested category 1 apixaban or edoxaban at least for 5 days of parenteral anticoagulation. So they suggested, so whenever you start edoxaban, give parenteral uh, for 5 days and then edoxaban. But for apixaban, you can start straight away. Or rivaroxaban also you can start straight away, but category 2A, because of GI sub analysis was shown. So that's 2020, last year, when I was talking about that time. CARAVAGGIO was not um, available. The result was not available. Then later on, CARAVAGGIO published as well. At that time, NICE also came up with the guidelines. So NICE actually suggested you have to consider DOAC as a first line treatment with VTE for cancer patients for 3 to 6 months. So they actually are saying that the DOACs are preferable over low molecular weight heparin. That if a DOAC is unsuitable, then consider low molecular weight heparin alone or low molecular weight heparin concurrently with warfarin, and then adjust the INR and remove the low molecular weight heparin as you were doing in the past. You have to prefer DOAC over low molecular weight heparin, because if we are these kinds of talk and this kind of lectures are very helpful, because it gives awareness to these community who are actually confronting these patients. So now the long term, we call it extended. They said, okay, for extended anticoagulation, you have to divide it into unprovoked and provoked. If it is unprovoked, then you can actually stop it, because it's okay. But if it is provoked, then you have a, a, a option to continue in a prophylactic type, or you can actually do some investigation whether they are still symptomatic, whether their cancer is under control, whether they're metastatic. So in that case, you can actually consider uh, extended anticoagulation. They assess the bleeding risk. Consider for extended anticoagulation for these patients. If there is bleeding risk is high, then do not give it. So that's why these patients need a lot of consideration, lot of time. Each individual need quite a bit of talk, and it need to be talked to the patient as well. What is the risk involved? So I think a dedicated cancer associated clinic is very good in this setting. Now, this is the most recent guideline, ASH guideline. So when I'm looking at the guideline, there are actually more than 20 guidelines. So this is the most recent guideline. So I will go through in detail this one. They are actually saying the first week you have to start DOAC apixaban and rivaroxaban for cancer-associated thrombosis or low molecular weight heparin for first week. So first week you start apixaban or rivaroxaban or low molecular weight heparin for first week, and then you can actually change later on to either or whichever, because the edoxaban was not given the first week in the first trial. So that's why they have excluded the edoxaban. And they have suggested that we do not prefer unfractionated and fondapaxine over low molecular weight heparin. So they have divided into three. So one is the initial treatment. This is first week treatment. And then there is a short-term treatment, which is 3 to 6 months treatment, which you can give. And the first choice is DOAC, apixaban, edoxaban, rivaroxaban over low molecular weight heparin. This is second phase. So initial phase and second phase up to 6 months, and then extended, which they call it long term. So we call it extended. In the NICE, they have mentioned as a extended. So three phase: initial treatment, long-term treatment, and extended treatment. They call it first week, long-term treatment, or short-term treatment and long-term treatment. In long-term treatment, you consider and discuss with the patient whether there is increased risk of recurrent VTE and what is the benefit ratio and what is the harm ratio with the risk of recurrent VTE and risk of bleeding. So you have to adjust and talk to the patient whether they need indefinite anticoagulation beyond 6 months. It depends on the oncologist. Sometimes GPs are they're not very keen, or they're not happy to actually continue anticoagulation forever actually. So these patients had to go somewhere. So that's the reason Gary and et al. Has suggested in their article these patients should have a pathway, a definite pathway for them to go and talk to someone, especially the person who is interested in this area, or a person, or even pharmacist, specialist nurse. So that pathway is only possible if we actually design a cancer-associated clinic. So there is a potential clinical implications of these three trials. So these three trials have actually allowed us to consider simpler oral anticoagulation therapy, but there are a lot of practical issues. There is GI cancers which can bleed. Whether they can bleed, they can bleed with apixaban or no, it's unknown. And there is an interaction between the lot of drugs. There is a cost as well. So there is a lot of pathways they have made. Okay, when the cancer patient comes, you have to just determine which anticoagulation you want to give. You select the drug depending on the renal impairment, whether they have drug to drug interaction, study their drugs, study their thrombocytes, blood parameters, and their life expectancy. If their life expectancy is less than 3 months, don't give any anticoagulation, and then go for DOACs if they are fitting into these criteria. So this is very good table for people who want to start anticoagulation for active cancer patients. So this is, you divide them whether their life expectancy is more than 3 months, yes or no, then go down. They have GI malignancy or no, renal impairment or no, liver functions, whether they have gastrostomy tube, what is their because rivaroxaban seems to be absorbed in the stomach. If they have no stomach, you can't give them rivaroxaban. You have to choose apixaban over top of it. So this was my article, which was published last year. So if you just Google Gilani and cancer-associated thrombosis, you will be able to find. This is very nice. I can show you here in this area. You can see here. And this is gives a flow chart to you, and it gives all the information how you select the patients for this treatment. And I will conclude now. So anticoagulation treatment for DVT or PE in the cancer patients. Offer patients with active cancer confirmed proximal DVT anticoagulation for 6 months, then review. When choosing anticoagulation treatment for patients with active cancer and confirmed DVT or PE, take into account of tumor site and bleeding risk and their risk of recurrent thrombosis. A direct anticoagulant is preferred. Low molecular weight heparin with vitamin K if DOAC is not suitable. Consider low molecular weight heparin on its own only if person finds oral medication difficult to tolerate or there is an interaction between different drugs. So thank you very much for your time.
Thanks very much for your talk. It was very detailed, and it was addressing one of the major issues in cancer patients, especially oncology and even post-surgical cancer patients. There was one question here, doctors, Mr. Kisku. He has asked whether is there any increase of VTE, venous thromboembolism, in ambulant skin malignancy patients? Should they also be considered for VTE? That is his question.
Yeah, so I will answer Kisku's question in a minute. I will just mention about Corona score. That probably will answer the question for Mr. Dr. Kisku as well. So whenever there is ambulatory patients, it is a prophylactic area. So it's not a treatment area, and Corona score doesn't apply for the treatment. This applies only for those patients who are very well and they have no DVT and no PE. They are actually are at risk of getting DVT. They are cancer patients. There's no point in churning guidelines over the guidelines. There are actually 25 guidelines available over the website. So we have to go for the latest evidence. So I have shown you the ASH guideline is the latest evidence, and that's what we have to follow. And the NICE is looking into it, and that's the latest one. So the Corona score does not apply for treatment of VTE. It applies to those well patients who have no VTE and no DVT, no pulmonary embolism. It is to assess the risk. It's a risk scoring risk. If the risk is very high for patients to get future DVT, then we can actually give them anticoagulation. So that I have not addressed today. So that I will address in future talk. So I have got a time for that in January. So I will talk about prophylaxis in cancer patients who are ambulatory, and I will refer to Corona score. Corona score is very good. We all should apply, and this usually applies to mostly oncologists. So if they are actually going to start chemotherapy to some patients, they have to assess the patient based on the Corona score. If Corona score is 2 or more, then they have to give them prophylactic dose of anticoagulation, either with low molecular weight heparin or with apixaban, 2.5 milligram twice a day. And Kisku's answer, I think, is the same. There is there is no need for anticoagulation for skin malignancy. Skin is two malignancies. One is melanoma and is non-melanoma. Non-melanoma, there is no need. If there is he's also asking prophylactic. I think more people are asking, more people are interested to hear about prophylaxis in cancer patient, because this makes sense actually. If we prevent thrombosis, it's better because that it will remove the burden of treatment actually. I address the treatment first and prophylaxis I will address later. If Corona score is more than 2 or 3, then you have to give anticoagulation in any patient actually, but it is only on cancer patient. It is only true for cancer patients because Corona score is not for non-cancer patients, and it doesn't apply to non-melanoma skin cancer.
Thanks very much, Dr. Gilani.